Thank you, Julia. So I'm going to whiz through some vestibular slides, and then we're going to break up into two practical groups where we'll look at cervical spine, we'll look at some vestibular aspects in the prac, so you'll have some time for questions and some deep dive in some clinical reasoning then. So in terms of vestibular dysfunction after concussion, it can be complex, but it doesn't have to be complicated. We see lots of different things. We see early on, particularly sensitivities to motion, sensitivities to eye motion, sensitivities to head motion, as part of the package after concussion, which is really, really common. We've got sensory motor integration issues. Basically, we've got brains that are just out of sync. And thankfully, for the majority of concussions, within 2 or 3 weeks, all those issues around being out of sync can come back into sync. That can come back in spontaneously, or that can come back in with a bit of encouragement from us in terms of some of the therapies and the advice that we provide. We see dysfunction, and somewhere maybe up to 75% of concussions will have some oculomotor and vestibular ocular functions that we will see. You'll see some technology today which makes it even more sensitive to see some of these things. And it's important that we have experienced clinicians and those people trained to be able to interpret these things to realise that what we're seeing, a lot of them will normalise, when to act in terms of referrals to people like orthoptists, and when to target them as part of our own interventions in vestibular rehab. We see central vestibular signs, which is really common, but it's different. It's a different kind of analysis of central vestibular than you say in ED with people coming where you're trying to differentiate a stroke from vestibular neuronitis. What we're looking at is we're seeing these subtle central signs that might be a combination of oculomotor and processing speed, cervical dysfunction, slowed saccadic eye movements, vestibular ocular gaze stability issues. So there can be a real mixture of different things. But we can also have peripheral problems, and we'll go through how common that can be. So we can have isolated nerve damage, you can have superior or inferior vestibular nerve damage, you can have BPPV, which is more common than we think. Pre-existing factors come into play here. We've got a lot of people out there who have had previous vestibular issues, they've had subtle vestibular issues before, they've got vestibular migraine, or they've just got migraine. So they have sensitivities there that we have to be aware of. We have to think how things are so interlinked, and it's important we have these conversations today because vestibular ties in with oculomotor and vision, and it ties in with the cervical spine, and it also ties in with cognitive functions and mood and anxiety. So we really have to think how these things interact. We haven't talked a lot today about autonomic function. We'll mention it in the tech because at the moment, as I said, I'm measuring my heart rate variability as we speak, but the autonomic nervous system does play a role with vestibular symptoms and exacerbates things. We've got the role of fatigue, and I'm sure Liz can expand on some of the research that she's done in our clinic around the fact that fatigue is likely to influence all things, but it does influence oculomotor function, it will influence vestibular. Cognitive reserve, the last decade, we've gone from thinking, does vestibular issues impact cognitive function, to realising, yes, well, absolutely it does. And how does it? And what are some of the cognitive deficits we see because of vestibular dysfunction in terms of spatial cognition, spatial awareness, processing speed, and all these sorts of things. And then finally, balance and performance. And it's quite exciting for me as a neurophysio because now I get to talk to all these high-level elite sports groups because they're not just interested in concussion now, they're looking at some of our testing and our things that we're doing with oculomotor and visual training thinking, hey, this is good for performance. And maybe we could implement a bit of vestibular rehab and a bit of these generic tests. We could do a bit more visual rehab in our training. So it's very exciting for me to talk to these groups where they're interested in what we've been doing for a long time, but from a completely different context. So really healthy conversations about that. So there's things to consider. So we'll just quickly go through. There's the neurophysiological stuff in terms of the metabolic cascade early on. There'll be vestibular dysfunction. It's very, very common to see this in the first couple of weeks after concussion. We've got a lot of the sensitivities. The VOMS examination that came out in 2014, which we'll go through in the prac, is important in terms of adding sensitivity to your diagnostic confidence of concussion, but also a realisation of how sensitive these patients actually are. Post-traumatic BPPV, benign paroxysmal positional vertigo, is more common than we originally thought. For those of you who see BPPV after concussion or head trauma or after an accident, realise that it's a little bit different sometimes. It's a bit more severe, it's a bit more recurrent, it's overlaying on top of other central and other neck and vestibular issues, but it's still, when you know what you're doing, relatively easy to treat, and you can impact people's lives within 1 or 2 sessions significantly, so we don't want to miss it. Peripheral nerve injury, if we suspect it, we need to follow up with more testing and to be able to understand what's going on to go through the adequate rehabilitation. The vestibular apparatus can be damaged. Vestibular migraine is more common than we thought as well. So if 15% of the population are migraine, if I stood up here 10 years ago and started talking about vestibular migraine, there was some ums and ahs, is it an actual thing? It is a thing. Vestibular migraine and migraine symptoms are common after concussion. There's a bit of nuances there to decide whether is it related to TBI or is it an overlay of pre-existing migraine, but either way we need to manage it. And oculomotor dysfunction, we often talk about oculomotor and vestibular together. That's because there's so much overlap between the two. We need to be ready for referrals. Vestibular rehab, there's more vestibular rehab clinicians around than ever before, which is fantastic. We might have to refer to neuro-otolaryngology in terms of more follow-up, more testing. Neurology are there to support us, to follow up if we're not sure what's going on. Of course, we've got the orthoptists, we've got, in some places, behavioural optometrists, we've got ophthalmology. So we've got the VOM screen again. We were very lucky last year in Brisbane at the physio conference to have Anne Muka, who was part of development of the VOMS test, to come out to show us how to do the test. But in terms of it as a quick screen, it only takes maybe 5 or 6 minutes. We can quickly look at some eye movements, both gaze stability, saccades, smooth pursuits, different directions. We can look at convergence just very basically. We can also do some motion sensitivity testing, and we're really interested in how much it provokes symptoms. So it really is a symptom provocation test. If you look at the data that's come out of the US in terms of from the National College of Athletics, they've done a lot of work around SCATs, and John talked about SCATs this morning, but if you add on VOMs, it adds on the sensitivities. Now, VOMs is important because, yes, it will help confirm your diagnosis, but often we are not interested in diagnosis. Well, we sort of are. We're interested in making sure that you get better. And so persistent VOMs issues can be a sign that you may be a bit of a slow recoverer because of vestibular dysfunction. And so therefore it's almost become part of, if you're going to have a concussion coming in, you will be doing a VOMS examination. So we'll go through that in the prac. I have to mention this because I'll mention some of the aspects of managing BPPV. It's more common than previously thought, and what's probably changed over the last 5 years is the fact, and this is actually the same whether it's the elderly or whether it's a concussion TBI patient, is that a lot of people have BPPV and they're not complaining of dizziness. So before we used to ask you, are you dizzy? And they'd say yes, and then we better check you for BPPV. Now we might say to someone, are you dizzy? They'll say no. But they might be foggy, they might have cognitive issues, they might be feeling thick in their head. The descriptions are different, there may be dysfunctions there. So we're getting to the point now where if someone's not recovering, you should be checking for BPPV. And in Australia, we're getting there's a lot more training in this country in terms of, particularly in the physio world, in training up in vestibular, but we don't want to become too specialised because there's just not enough of us around. So I'm a very strong advocate that more people know how to treat the basics. And if you think there's going to be 36,000 people with persistent symptoms in concussion in Australia every year, some of them are going to be requiring to have this checked. So in one study, there was 51 out of 167 cases, so 31% were diagnosed with BPPV. We can often treat it in one treatment. That means maybe in 5-10 minutes, you've gone from someone who's symptomatic with major issues to being fixed. We do a lot of training around using the correct positioning manoeuvres. There's still some old manoeuvres out there like the Brandt-Doroff that we hope people stop using now, and I'll go through that in the demonstration. If you're not confident the manoeuvres or the manoeuvres you did don't work, we know we've got more vestibular physios around now with the confidence and training to follow up for you. It is a high recurrence rate. Just BPPV is high recurrence. What that means is that people can get it again within 6 to 12 months, and it's not that uncommon. Unfortunately, when they get their BPPV back, it may not be exactly the same kind of BPPV they had 6 months ago. So the treatment that worked for them, they'll do it at home and they'll try and fix themselves. It might work, and it may be worth them trying that, but if it doesn't, they know they can follow up and we might have a slightly different manoeuvre. The evidence has been really pleasing in terms of, here's more Australian research. Sue Reed led this systematic review in terms of looking at persistent symptoms after concussion, and basically said 3 times more likely to return to sport by 8 weeks if you have an early focus on neck, vestibular and oculomotor or vision training. Now, if you look at the literature, each one in isolation has some benefits. You could do some vision training, you can do some vestibular rehab, we could treat the cervical spine like Julia said, and it's all very important. But we need to cross-pollinate a little bit more, because if we combine all those skills together, we start getting the neck moving a bit better, the head more stable. We pair that with some eye movements, which is specific to their activities of daily living or their particular sport. If we add in some visual training into that, what we're trying to do is we're getting people back in sync earlier, we're getting them confident, we're getting them moving well. They're less likely to have more complications and add-on issues. So if you can combine your skills, and we do a lot of training now where you'll have physiotherapists, for example, really confident in vestibular rehab, but they're not confident with necks. And we'll have sports physios who are quite confident with their cervical assessment and screening, that kind of stuff, but they wouldn't know where to start with coming to check for things like BPPV. So the world's changing now. We're going to cross-pollinate. We're going to do a lot more training together because there's a large percentage of people out there who will benefit from these skills. And then there's a lot of people who have got the appetite for this kind of training. So in terms of dizziness, you can split it up. We've got central things. We've got the motion sensitivity. We've got the central vestibular dysfunction. We like to see that resolving pretty quickly over time. Peripheral stuff we need to treat. We'll treat the BPPVs. If we're not sure, we'll refer on to people like Nicole and Lauren for more vestibular testing to find out what exactly is going on to isolate the issue and refer on if needed, but then we can focus our vestibular rehab with more confidence. And then there are other things that are the oculomotor changes. There may be a nerve palsy, there may be cervicogenic issues. We've got the overlay of anxiety or possibly PTSD, like Julia said. And then a functional overlay, which is not uncommon in the TBI population, as you know, can come into play as well. When we do vestibular rehab, it comes under a number of things that we're going to do. We're going to check for BPPV. We're going to look at your ability for gaze stability functions in particular, and we can combine that with cervical stuff quite easily. Head stability is a really interesting field because of mechanism of action with concussion and also the fact that we need to get people stronger. Liz and I, we tend to see a lot of patients, don't we, who are footballers who have very weak necks. It's quite concerning, so we feel like we need to get them stronger, we need to get them more stable. It's probably different in Queensland with the rugby players with much stronger necks. But they're serious issues. When we baseline screen, we see these people, we're finding lots of things they could easily build into their rehab programs. Tolerance, adaptation, habituation, the mechanisms for action. We've got balance issues that we need to add into it. Cervical manual therapy. So it's not all just exercises. We're trying to get people to move better. We're adding specific movements to specific segments of the cervical spine to match with their vestibular movements. Aerobic exercise, well, it's really nice in the concussion world because people are encouraged to do aerobic stuff earlier than ever before. So that can be happening simultaneously while we're doing these other things. In fact, if the University of Loughborough are telling us we can do sub-threshold aerobic exercises 48 hours post, and then day 3 or day 4, gentle cervical spine, gentle gaze stability. John Patricios is very keen for some very generic exercises that they're not specific. You haven't come up with specific diagnosis, but there's little things where you can get people moving early which could get them off on a good path. A lot of these people, they'll be non-complicated, but at least the people that are complicated have started a healthy process earlier. So I used to be very anti-generic, saying you've got to make sure I'm trying to get C3, 4 moving more lateral flexion, improve their gaze stability and head stability. But a lot of these patients, there's just too many of them. We've got to get them moving. We've got to use sensible approaches. And then as soon as we feel like we're stuck, we've got the right people we can refer to. When we do BPPV treatment, we talk about these canal repositioning manoeuvres. if you work in the vestibular world like I do, and you become a bit of a vestibular nerd like I am, we're just constantly inundated with new manoeuvres. Every 3 months there's a new manoeuvre coming out of South Korea or Italy, and there's a new treatment for BPPV out there. On the left-hand side, there are many options we use in our clinic in terms of Epley's manoeuvre, the Samont manoeuvres, there's the Lee manoeuvre, there's Appiani manoeuvres for horizontal canals. We've got the barbecue roll, which is, yes, you'll understand why it's called the barbecue roll. We've got another Lee manoeuvre for a horizontal canal, the Kim, the deep head hang at Jacovino. These are all different manoeuvres for all different kinds of BPPVs. It sounds complicated, it can be a little bit, and there's clinical reasoning involved, but the ones on the right will still treat most of these. And so your success rate might be right up there at 90% if you could learn the Epley's manoeuvre and be happy and confident with doing that. If you can do a very good barbecue roll, and also if you can do the Lee manoeuvre, which a lot of our patients can do at home or on the hospital bed, or they can do it in the nursing home, and it's quite easy to do, you will treat a BPV quite successfully, even if, God forbid, you don't really know what you're doing. So it's quite exciting. Don't tell anyone I told you that. I'd get in so much trouble. But the thing is, there's a lot of treatments you could do that will work as long as you're not going to be holding on to those patients. You can refer on when you get a little bit stuck. Tips. You don't need to have dizziness to test for BPPV. That's changed our practice. Be aware of BPPV mimics. So when you do the training for BPPV and you're seeing positional nystagmus, we see positional nystagmus in central positional signs. We see it a lot with migraine. So it's just having a couple of skills there to differentiate those things with the training. The stuff, in terms of the VOMs and symptom provocation, and the stuff you'll see today in the technology like oculomotor and vestibular ocular stuff, say, that we're going to see with the Neuroflex, we're not testing the same functions. One, symptom provocation, while looking at the eyes generally. The other's much more detailed examination of things like saccades, smooth pursuit, gaze stability, optokinetic nystagmus, and all these kinds of things in much more detail. So they're not the same thing. Sometimes they'll correlate with each other, and sometimes they don't. So keep that in mind. The cervical, vestibular and vision should be considered together, both in your assessments and your treatments. Brief and minimal symptom exacerbation is okay. We're really pushing the fact that you don't want to wrap these people in cotton wool anymore. We do need to get them moving, and we can move them in with a methodical way. And remember the possible contribution of other things. The autonomic dysfunction is really interesting. Heart rate controlled exercise is a really big part of our practice. We can fall upon the buffalo treadmill and bike tests when we need to test things more in a more structured way, when we need to say, do we need to refer, if we do that, the nasoline test with the orthostatic testing of blood pressure, do we need to refer to a cardiologist to follow up for possible POTS? These things are important because we don't know how many POTS we could possibly save through, like John said this morning, through getting people into early adaptive exercises. And if you treat POTS patients, which a lot of you probably already have, it can become very, very difficult. Now, we're going to look at technology this afternoon, and it's important that we don't end up like the picture here is providing all this effort trying to bring in tech, and it just makes life a lot worse. Now, I've been involved at Flinders University. I've seen a lot of technology come and go, but I've also been running a clinic. And so at least we will talk about technology which actually we're using clinically. It's quick and efficient, it's valid and reliable, but it's giving us good information. And while we're doing that, we'll also get the evidence. The Neuroflex has changed our practice in terms of the last 3 years we've been using it. Before that point we weren't, which means we're now seeing things with the eyes that we just didn't even know about before. We didn't know to refer to orthoptists like with Tanya this morning because we just didn't have the sensitivity of the tests. The evidence is here over, just building over the last 6 to 12 months in terms of multiple objective oculomotor vestibular ocular signs are observed with VR eye tracking tech after concussion. Evidence shows dysfunction following concussion in both adult and children populations. Really interesting study that came out a few months ago looking at how that correlates with fMRI data to have a real appreciation of, as a biomarker, very different brain networks involved in oculomotor and vestibular ocular function. And also just the whole idea of repeat baseline data and how it makes our life a lot easier in terms of interpretation. What we've learned is that Knowing an athlete or a person's premotor oculomotor status would likely be immensely helpful during a post-concussion evaluation, and this is the truth. I've been involved in looking at some of this tech and some of these vestibular examinations in isolation. Like most concussions would come in, I'd never knew them before. Now I'm assessing people, I'm consulting people from all around the world, and they're sending me their baseline data and their new concussion, and it's a complete game changer in terms of being a lot more clear about what may be changing and what's not. So here's an example of when you've got baseline testing and you've got a concussion. This is a 15-year-old kid. He had a concussion, which is C1, playing soccer, and then 6 weeks later had another concussion. So unlucky. He's one of those ones that within the guidelines now we'd have more of a conservative approach, but this is just one of the 63 metrics that spits it out in your 10-minute examination with the Neuroflex device. You've got a baseline data here. You can see the number of saccades during the smooth pursuit increases, which we don't like. Quickly recovered, you can see, then had secondary concussion, increased saccades again, quickly recovered. Then there's a couple of other baselines showing, giving you confidence that this kid is back to his normal with that particular function. Look at a different function. Oh, hang on, did I jump one? Here, saccades. Processing speeds come up a lot today, whether it's auditory or whether we're talking about, simple reaction time, which we've got devices we'll show you later on, but also here with saccades. You can see he's come out of the normative range with that first concussion, dipped back in pretty quickly after concussion, and then came out again. So mean latency with saccades and anti-saccades is something we definitely look at a lot when we're screening with oculomotor functions. But you can see how that's given me confidence that he's recovering. There's probably no interventions at this point, but it's the confidence with baselines that's giving it much clearer. If you're just getting, so I'll try and point up there, if you're just getting an isolated score here, I could have, and I've just gone through 20 AFL players, if I've got their baselines, if they're up at a different level and it's just normal for them, then I've got less confidence in knowing, is this something that needs to be followed up, or is this normal for that person? So baselines is really making our lives a lot easier. And anti-saccades, here's just another example. So it's obviously coming out, quickly recovering, and you can see the next baseline also gives us confidence that this person is doing quite well. But here's a different example. Here's someone playing in SANFL, our local competition of football, who had a knock, was slow to get up, but the physio did the right thing, did a SCAT examination, SCAT 6, which John talked about this morning, and then a follow-up SCAT 6, and everything was normal. But just for precaution, came to our clinic on day 4 for a check. I'll double-check everything. Everything was looking good. We even did the Neuroflex test on him, and you can see that this particular club was one of the ones where we were involved in some baseline screening back in very early February, and then we looked at a lot of his measures, so saccade latency in this example, or number of saccades and smooth pursuit, and there are many other measures we can look at, but it gave us confidence that he's going okay, and he was. So it's all about confidence, it's all about being selective who you show these graphs to, which patients do you show them to, give them confidence that they're going all right, that their brain is recovering, and then they can move forward with their rehab. So in terms of practical knowledge, we want to make sure that you become familiar with the VOMs. We want to know when you do an oculomotor examination what to look for. We want to make sure that you're aware of cervical influence. So we actually in our clinic do the VOMs plus the smooth pursuit neck torsion test that Julia mentioned at the same time, because you can quickly add it on. BPPV, for looking at positional tests, being able to do BP treatments using our favourite, our top 90% good ones, being able to give gaze stability exercises, head stability exercises and strength, but also retraining in terms of dynamic balance and task specificity. So a lot of that task specificity might be in relation to work, it might be in relation to their sport. It's very easy for us to have conversations then with other medical teams and other people to bring in that expertise to make sure that we can, use our skills, they can use their skills, and make sure that person's going through a tailor-made return to play, return to work, return to learn program It's not just about waiting out your 21 days. Within that 21 days, there's a lot of little things that we can put into place to make sure that that process is going to be as good as it possibly can.
Thank you very much. I'm hoping that I'll give you an overview of the role of the cervical spine post-concussion. So we're going to talk about what has the neck got to do with anything, perhaps some things for recognition and screening if you're not a physiotherapist or you're not a musculoskeletal physio, what sort of assessment that a musculoskeletal physiotherapist would do looking at the cervical spine post-concussion, and then what that management might look like, and then we'll touch briefly on prevention. So when we think about potential damage with head and neck trauma, you can see that to have a concussion, it's about 60 to 180 G-force, but to have a neck injury, it's about 4.5 Gs. So it's most likely that if you've had enough force to cause a concussion, then you've also had enough force to cause a neck injury. The other thing is that neck pain often causes impairments, so we have things like decreased range of motion, dysfunction in the joints, changes in the way the muscles work, and also in the morphology of those muscles. They also have pain and can have nerve sensitivity. And this can all change afferent input from the cervical spine, which can then cause sensory motor control disturbances, dizziness, visual disturbances. And we also know that the neck can cause headache. And so both of those things are really very common signs and symptoms in persistent concussion. So how does the neck cause sensory motor deficits? So the neck has a really unique anatomy. So it has a really high percentage of muscle spindles or afferents that send information along with the vestibular and the visual system into the brain to provide input for eye movement, head movement, control and postural stability. It has, and so in the suboccipital muscles in your neck, there's about 240 muscle spindles per gram, whereas in your thumb, which you would think is a fairly sensory organ, is only 16. So they're there for a reason, and that's because they have this high connection between the inner ear and the eyes, and we have reflex connections directly to the eyes and to the vestibular system as well. And then we also have these very unique connections to the brain and to certain parts of the brain that send the information as well. And we know that if we do things to these afferent inputs, so if we anaesthetically inject the joints or if we vibrate the muscles, then we can cause people to have ataxia, visual disturbances, dizziness, etc. So in this way then, we have proprioception, but probably a lot from the neck, visual and vestibular input that then is integrated to give us this sensory motor control. And so that can cause these things like dizziness, unsteadiness, visual disturbances, loss of balance, etc. So how does the neck cause headache? So we have nerve input from the upper cervical nerves, so C1, 2, 3, and that gets sent to an area of the brain called the cervico-trigeminal nucleus. And this is the same area of the brain that the trigeminal nerve and your head, so any area of the head goes into as well. So the two areas are converging together. So because of that, neck pain can refer pain to the head, but we also need to remember that headache can also refer down into the neck as well. So why is the neck important post-concussion then? So as I've said, the neck can cause headache, dizziness and visual disturbances, which are some of the main symptoms. It is actually quite common post-concussion. It's been sort of bandied around anywhere up to 69% of patients with post-concussion will have neck pain. We also know that if patients do have neck pain in association with their concussion, that they might have a poorer outcome. And there's also evidence of impairments in the neck in patients post-concussion. One of the problems is that the neck is not always considered, and often it's not even assessed. And a systematic review found that, it wasn't assessed or looked at in a lot of times. The problem is that the treatments will differ. No, we need to know what's causing it. So if it's coming from the neck, the type of treatment that we would do would be different to the type of treatment that we would do for a vestibular or autonomic nervous system function problem. The other thing we need to think about is that we do know that people have an increased risk of having another concussion or a musculoskeletal injury post-concussion. And we also know that perhaps the neck is important to be able to generate enough force to prevent these high impact on the brain. So if we've got ongoing deficits in neck muscles and we can't generate those forces, is that a problem for prevention? So the big problem we have is that the presence of neck pain is not that simple. Just because you have neck pain doesn't mean it automatically means that your headache is coming from your neck or your visual disturbances are coming from your neck. And so, we know things like people with migraine, tension type headache, they can get referred pain into their neck and not have a neck problem. Visual problems, so if you put your fingers on your muscles at the top of your neck and just move your eyes side to side, you'll feel those muscles firing up. And so if you've got a primary visual problem, that can definitely drive a secondary problem in your neck. And similarly, if you've got a vestibular problem and you're really trying to avoid moving, then you can get a secondary neck problem from that as well. And also things like TMJ. So just having neck pain doesn't really tell us too much. The other thing is that the role of the neck in symptoms like headache and dizziness is also not very simple. And so, as I mentioned, it could be primary. So it could be primary cause, and that's fantastic if you're a musculoskeletal physio. It could be mixed, and we know about 60% of people who get dizziness have two types. So it could be that they have some kind of dizziness that's coming from their neck, but they also have vestibular dizziness. It could be not cervical at all, so it could be that they've got neck pain but they've got migraine or tension type headache or vestibular migraine. It could be secondary, and this happens a lot post-concussion where they've got neck pain but it's secondary from their vestibular problem or their primary visual problem, and they're the things that are driving their neck pain. We need to be able to tease all of that out, and it's not going to be that simple. So in terms of screening then, if you're not a musculoskeletal physio, the suggestion is that, perhaps we could look at things like range of motion of the neck. We could palpate the muscles around the neck. We could look at proprioception, and we could look at a sort of an idea of neck muscle function with a head lift test. And these are good screens, and I think if those tests are all good and they haven't got any problems, then perhaps we could say that the neck probably doesn't have a role, but we could also get some false positives. So if we're palpating the muscles in someone with tension type headache or migraine, they might report that they are painful, but that's not a neck problem necessarily. It could be incidental findings, and so we have to think about, is this a cluster of findings that you might expect in someone who has a musculoskeletal disorder? And it could be coexisting. So we know that if you've had enough trauma to cause a concussion, you've probably had enough trauma to cause a neck injury, but are they related? Is the neck related to this dizziness or to this headache? And we need to be able to work out what's the main driver so that we know what to treat and when. So I think if any of these things are present after you do that initial screen, then it's important that you refer on for further assessment and a more extensive assessment where we can really decide what's going on and what is the role of the neck in this presentation. So the sort of assessment that we would need to do is really using that integrative approach. So we really need to think about what the patient's telling us, what their symptoms sound like, what's being aggravated by, assess those impairments that we find in the neck, and really do a skilled examination so that we're not just relying on the patient telling us it's painful. and then trying to determine the interactions and contributions from each of the systems. So we may be looking at the autonomic nervous system, the vestibular system, cervical, visual, and then other things like migraine, tension type headache to try and work out the role of the neck in these symptoms. Can pathology be identified? So in patients with neck pain, often not. So, patients who have whiplash injury, for example, commonly will have scans and it won't show anything. And sometimes that is because we don't have the technology and the advancement in things to show that. But, is that a problem? Probably not. They're not going to have surgery. What it might help to identify is why somebody might be having prolonged symptoms if we can identify something, but we don't necessarily have to. We know that there's often a peripheral driver in these patients, and there's been studies where they've done things like done a radio frequency neurotomy, burnt the nerve in the neck, and then a lot of their signs and symptoms improve, and then as the nerve grows back, that those symptoms return. So we do know that there's often a peripheral driver in these patients with whiplash. That's in terms of the potential pathologies, so it could be, if you think of it like an ankle sprain. So if you might have had an ankle sprain where you've just gone over a little bit and it's a tiny little bit of soreness, you can still walk on it, you can still maybe even run on it the next day, all the way through to somebody who's really done a number on themselves and they are non-weight bearing and they're having to use a boot and crutches for a little while. So that's the sort of spectrum of things that can happen in the neck as well. It could be just a muscle strain, but then more severe things can be even things like, bleeds into the nerves and those sorts of things. So when we're doing our assessment, we're looking for a cluster of musculoskeletal findings. So we shouldn't just find some deficit in range of motion and then their muscle system is fine, because that's not what we see in a normal musculoskeletal disorder. If you've got something wrong with your knee, you can't bend it properly and your muscles have wasted. So, we see this cluster of signs, and that's what we're looking for when we're trying to work out the role of the neck in concussion. So we look at, we do a manual examination, we look at the way the nerves move, we look at the way the muscles are functioning, and then we can do tests of sensory motor control as well, looking at that with respect to alignment and movement. So our musculoskeletal examination would look something like this, where we would look at range of motion, do a manual exam, look at the muscles and also strength as well, strength and endurance. And our cervical sensory motor examination, and you'll see that some of this crosses over with what some of the things that we'll be talking about in the vestibular system, but we can look at things like walking and comparing inputs. So, for example, walking compared to fast small head movements compared to large slow head movements, which might give you an idea of whether it might be more vestibular or more neck. We can look at things like trunk-head coordination, eye-head coordination, which can be impaired in people with neck pain. And we can look at smooth pursuit, but we add what's called neck torsion to that. And so we keep the head still and we turn the trunk. And what that does is it changes afferent input. And if that changes somebody's ability to do a smooth pursuit eye movement, then that tells us that the neck is influencing that. Okay, but we must compare it, because they might not be very good at smooth pursuit to start with, but it's only if it changes when we put them into that torsion position. And then we can look at tests of joint position and movement sense, which are tests of proprioception, and then we can use some other tests which will go in the prac to talk about how we might be able to change some inputs to see if we can see whether it is more vestibular or more visual or more cervical. And so one of those things is looking at the effect of neck torsion, and so we can use that. We do it in, this is doing it, instead of relocating the head on the trunk, we're just relocating the trunk on the head for proprioception, and we do it for eye follow, but we can also use it for convergence and for balance as well. So then after we've done that sort of fairly extensive assessment, then we need to try and put it all together. So do the signs and symptoms, what the patient's telling us and what we've found in their neck, does that match up? And does it match up? Does it make sense? And if it doesn't, then we need to make some decisions about what we think the role of the neck might be in those, in that patient. So we might do our assessment and not find anything wrong with their neck, and so we decide the symptoms are not coming from their neck, there's no role, and you know, in the case of migraine or tension type headache, it may just be that their neck pain is referred pain from their headache. It could be that it's a red flag and that's something more sinister that we need to consider, so something like a cervical arterial dissection, which may present initially as neck pain. So in those patients, we would not consider neck treatment and we would be referring them on. We also might decide that it's not cervicogenic, they don't have a cervicogenic component. It could be that they've now have some cervical sensitivity, and so we see that in migraine as well, and tension type headache, where because of that constant referral into the neck actually becomes sensitised, so it doesn't like moving, it doesn't like to be touched, but it's actually more a sensitivity problem rather than a muscle dysfunction. And so in that case, we decide that it's not cervicogenic, but maybe it's a trigger. So maybe in those patients, we might treat the neck to help improve migraine or tension type headache to see if we get a change. We might decide that it's a secondary cervical musculoskeletal problem, and so we might think that the visual problem and their main problem with vision is driving their neck problem. And so in that patient, we can still treat the neck for symptom relief of their neck, but if we don't send them off to the orthoptist, that's what we're going to need to do, because it's just going to keep coming back. We will get their neck pain and headache settled, but then they'll go out into the big wide world and their vision will still be messing with them, and they'll come back all the time with their neck pain and headache. Similarly with the vestibular system. So if the vestibular system is driving their neck pain, we need to sort that out. And then certainly we might decide they have got a cervicogenic component that is causing their dizziness, is causing their headache, and that's fantastic. We know that we can treat that effectively. But we also, very often, post-concussion, we have a combination. So we have a mixed. So we'll have somebody who has some sort of unsteadiness that's coming from their neck, but they might also have a vestibular component that's causing some vertigo, or they might have a headache, or two types of headache, one that's very neck-related, one that's visually related, or one that's more related to exercise intolerance. And so it's really working out, what do you treat first, and those sorts of things, and the contribution of each of those. So overall clinical reasoning decisions will be to work out what you think the role of the neck is, what's the drivers and the interrelationships between those things. And sometimes the neck can really be a driver for visual problems, and so we need to consider that. And so in every individual patient, what the size of those boxes are is going to be different. And sometimes the cervical might be a really tiny component, and in others it might be a big component. So in terms of the management approach then, so post-concussion, the problem is that it's not going to be the same in everybody. Neck pain is never the same in everybody. The presentation will be different, so some people will have headache, some people won't, some people have dizziness, that sort of thing. The pain types and the source can be very varied, so they can have just a very nociceptive type pain, or they can have a nerve or neuropathic type pain. The functional things that are a problem can change, and the impairments and the nature and severity of those can change as well. So the emphasis really is on clinical reasoning. There's no real recipe approach, because we have to use that individual approach with the evidence base in mind. So is this the same as whiplash? Well, you know, again, with whiplash, we get a spectrum of patients as well. 50% of those patients will improve if you don't do too much, and 50% of those will then range from a spectrum of mild all the way through to very severe chronic symptoms. So the only thing I think is that the new guidelines for whiplash will be coming out, or if they're not out, and so they tend to look at it in terms of low risk, moderate to high risk, and then they stratify the care according to that. And so that's probably a little bit of a different way of thinking about things that's been driven a lot by, you know, insurance and trying to, you know, give, treat and use, you know, we've got limited resources, so trying to really treat the patients who have more need. There's also quite a few psychosocial considerations with whiplash patients. A lot of them get post-traumatic stress, not a lot, about 20% can get post-traumatic stress type symptoms. And so, you know, it is slightly a different beast, I think, that of the types of people that you see post-concussion. But if you are interested, there are some fantastic website. My Whiplash Navigator is a fantastic website that has resources for clinicians and for patients, and it has, you know, exercises and shows you how to do assessments and things like that as well. So the management approach will be to improve neck pain and managing pain, to rehabilitate any physical impairments that we find, to try and restore them, restore function and participation. But we need to do it integrating it with the other systems, because our concussion patients are likely to have visual, vestibular or autonomic nervous system dysfunction as well, and so we need to be able to treat them all at the same time. Sometimes neck treatment enables other treatments, so if somebody's got a significant neck issue, then they can't do their hectic vestibular rehab sometimes, and so sometimes it might be that you treat the neck first, sometimes you treat the visual system first, and so it really does depend. So in terms of our treatment, we would be focusing on posture, ergonomic and work practice advice, really trying to get the muscles that help with postural control and stability of the neck to be working on a regular basis. We would manage movement and segmental joint dysfunction, so we can use manual therapy, we can do exercises to try and improve movement of the specific joints in the neck and also down into the thoracic spine, because the thoracic spine often gets stiff and we need reasonable movement of that so that we don't have to overuse our neck. In terms of rehabilitating neuromotor control, so we get changes in the muscles become inhibited, they lose strength and endurance. So what we tend to do is we'd have a two-phase approach. So the first phase would be to try and activate muscles that are not working well and to try and get them going, and then we would progress into a strengthening and endurance kind of phase. And the sensory motor control aspects can come at that first phase, and then we can do more integration at that later stage. So I'll just touch on prevention now. So there's a little bit of talk about the fact that we need to be able to generate force in our neck quickly, so that if we do have a concussion, we're able to limit the forces being transferred to the brain. So, you know, the evidence is a bit mixed for this, but I think in terms of things that we can be thinking about doing, and if we know that our patients, even if the neck is not causing their particular symptoms, if they've still got neck muscle dysfunction, then from a prevention point of view, it would be important, particularly if they're going back to sport, to try and help improve that as much as we can. So some of the things that have been suggested are things like really trying to improve strength and endurance, looking at the ratios between the muscles at the front of the neck and the back of the neck, trying to improve segmental mobility so that people are not very stiff at one level and they've got, you know, good movement throughout the whole neck so that forces can be dissipated, that they've got good head stability so that if they get hit they're able to generate force, and that they've got good head reaction and force production time, and that they've got good movement precision and know where their head is in space and have good proprioception. So I'd just like to acknowledge the Neck and Head Research Unit and our collaborators who help us do our research in all of these areas, and just hope it gives you a bit of a cook's tour of the neck.
With green, backwards with red.
Amazing, beautiful, thank you. Thank you. And yes, I will definitely say I'm extremely passionate, obviously, when it comes to concussion. And from what I've learned today, I think we all share that in common. Today's been an amazing experience. I feel like it's very rare when we get so many people in the same room that share the same passion with trying to bridge the gaps in this field. But I think we're doing a marvellous job at it, if I may say so, after, conversations we've had today. I think we're, all putting in a little bit here and there, and we're slowly making progress. So very exciting. So what I'll be doing, I'm going to be talking very briefly today, or this segment I should say, is more about just getting stuck into it with technology. This isn't technology that's, so far in the future, but more so what we're using in clinical practice already. So it's very exciting stuff. John and James have made mention and summarised it really well today, where technology a lot of the time is so valuable to our assessments, but it's not everything. So keep that in mind, is we've got so much technology to help add value to assessments, make things more efficient when the technology works, I should say. But also just keep in mind that as clinicians, we need to clinically reason just as much as before and perform all of the other tests in conjunction as well. So in terms of the domains of use for concussion and technology, we're thinking about data collection and reporting, especially in the research realm. Diagnosis is becoming bigger, so we're talking about vestibular oculomotor biomarkers, also biomarkers with blood tests. I'm sure a lot of you have seen that coming through in the literature and in the media, so I think that will be an evolving place to just keep our eyes on, which will be fantastic when and if it comes along anytime soon. As well as in our assessment and tracking. We can already see with things like the NeuroFlex, we use that quite heavily in conjunction with things like the VOMs, with assessing vestibular oculomotor deficits. It helps with providing so many metric data points that then we can hand over to, say, people like Tanya, who are experts in the field, with helping us work through things like vergence issues or abnormalities, as well as latencies, things like that, to figure out what's going on. We use it in the provision of therapy as well, so we probably use it much more than we think, and that goes anywhere from vestibular oculomotor training to, sub-threshold exercise and monitoring heart rate variability. Speaking of, where is James and his heart rate variability? We need to track how that's going, and we'll have to look at that at some stage before we finish. Red lights, okay, he's stressed, guys, he's stressed. So things like that we're just integrating into clinical practice, which is fantastic. As well as James mentioned earlier, performance, and that's a huge space when it comes to elite athletes. You try to tell them that they should do this to get them better for concussion. They kind of glaze over a little bit sometimes, unfortunately. Then all of a sudden you mention performance, and they want to know more. They want to know how they can engage and how they can perform better. So sometimes that's the in. We'll take it as long as it's improving their brain health. Let's do it, I say. So in terms of what we're going to look at today, so we can see NeuroFlex demos going on over here. I think we've got a couple of devices, so definitely see what David is demonstrating with Sean there, the model, and it's very fascinating stuff. We also have the Vesticam. I'm not sure if you saw that when James was doing positional testing, but that's a great added device that we can use to get really thorough understanding from an oculomotor point of view. Autonomic dysfunction. This is a really fascinating field, and heart rate variability is something that's coming more to the forefront now post-concussion, and that's our body's autonomic response, or our response to stress. They found that post-concussion heart rate variability is something that can often get affected, so something like first beat technology can help us quantify heart rate variability and track that throughout the day, and it can give individuals quite good feedback. So that's great stuff. On top of that, we've got stuff to measure balance, whether that be force plates. Today we've got the balance mat, which is quite easy to transport around if we're doing, say, baseline screenings or just in clinical practice. That can just give us more sensitive data to do with sway data on top of errors that we might do with a modified BESS, for example. So it can be quite handy. Things like coordination, just simple as reaction timers. There is a paper published with normative reaction time. Previously, we would use the drop ruler test. This is just a little bit more sensitive, so that's another addition, as well as symptom tracking. We've got great apps out there now as well that are listed there on the screen. Also think outside of the concussion realm as well in terms of symptom tracking, because sometimes we get secondary things pop up like migraines. So there the clinical picture might move from it being a persisting concussion picture to then being more so a migrainous picture. So things like Migraine Buddy can be a fantastic app to help individuals track their migraines, so we can profile it. So then if we're doing a referral to neurology, they've got all the information ready to go. So what we might do is we might get back into it. Like I said, David's going to be doing some demos there, which will be fantastic. I'll put the screen up for, here's just some other technologies to keep in mind as well. That's all kind of going on in the background, but we don't have some of them here today. But here's just a bit of background of Neuroflex, but I'm sure David will speak through that. But come have a look at what we've got going on over here. We've got Balance Mat as well as some other technologies as well, and Neuroflex. And then you can just use this as question time as well. Have a chat if you've got any questions maybe from the whole day. Feel free to come to have a chat to any of us. But thank you for paying attention, making it to this point in the day. You've all done very well. Thanks.
The main aim of this was just to have a quick chat, but also stimulate some discussion amongst you all about where do we go from here. A lot's happened in the last 2 to 3 years with this field. If we did this talk again now in 2 to 3 years' time, what will we be talking about? There's been a paradigm shift, there's no doubt about it. The evidence and the guidelines is changing practice, it's changing our expectations of what we need to know. There is the background concern from legal obligations of what we should be doing now too. So for some people, it's a nervous time of litigation. We do really want to make sure from today, and we want to help facilitate this, we want you to build your network. We don't want to brag about how cool it is in Adelaide because we've got all these wonderful audiologists and orthoptists, which is true, but we also want you to find your people as well. And we feel like that building of network is extremely important. The concussion officer role is a new thing. It's very much come out of those AIS guidelines. The concussion officer does not need to be a concussion expert. The concussion officer will be a facilitator, will be the person that makes sure protocols are followed, people seeing the right people, that people got medical clearances, these kinds of things. So whether it's a workplace, whether it's your local footy club, whether it's an AFL club or an NRL club, it doesn't matter. There'll be the evolution of this role. We don't think it'll just happen like that, but it will probably happen over the next 2 years. But the evolution of that role and how it will bring in health professionals like you guys will be really, really important. And then the other thing we've got to ask ourselves is what are the research priorities? And you go to a talk like today and start thinking, well, what's next? What do I still have unanswered questions around how do I screen for this? I've got lots of questions from today listening to some of the talks, which has really got me thinking about how can we improve things for our patients. We've been talking about the end-to-end concussion management pathway a lot at Your Brain Health. What we're trying to do is create a model that's not too complicated, but everything from prevention preparation to acute management, early interventions, persisting symptoms to ongoing care, that we feel like that we've got a foot in every door. We seem to be, we as an organisation, and therefore you, have an idea of what are the key research questions, what are the key clinical questions to make sure that our patients aren't missing out. There's a few things that have happened in terms of education. There's education that we've actually done through Your Brain Health. We've spent the last 2 years with a lot of work on this. So there's concussion update course, particularly for that concussion officer role. It's only 45 minutes online. We've got an evidence-based update that's now really focused on GPs and health professionals, which is 60 minutes long. Then you can talk to Liz about this, which is the concussion rehabilitation and management, which is 10 plus hours with lots of resources, which is really going into, the depths of rehabilitation, multimodal management, which we think is really important for those of you interested in this field. We've got school modules for years 9 to 11 kids to learn about brain health and also just to learn about concussion. So we've got big issues in schools with kids not disclosing their symptoms, worried about missing out and playing sport, and just getting the balance right, but not getting too anxious about concussion. There's a lot of anxiety now about concussion and CTE, but then we also want them to take their concussion seriously. So, but it's not all about concussions. We've actually got a module completely about brain health. We want them to know about dementia. We want them to know about the modifiable risk factors for dementia. We want them to realise what encompasses good brain health as they grow up. And then we've got face-to-face workshops which we really run through what we try to do today at 1,000,000 miles an hour, but take a little bit more time and a little bit more depth to make sure that people leave confident with things like VOMS cervical assessments, vestibular assessments, and being able to follow up on all those really cool questions we've had here about autonomic function, etc. In South Australia, we've got the South Australian Sports Medicine Association. They've had a government grant and they've been extremely successful in getting education out to trainers and to clubs and to organisations. Like, it's spectacular how much they've managed to do over the past 12 months, and they're continuing to do it. So we recognise what they're doing and support that. So if you're in South Australia, you could look at that. And then, of course, nationally, we've got Connectivity, Traumatic Brain Injury Australia, with some short courses on there. And also, to make a mention of the research you'll see around, there's some research flyers around the MTBI, MTI, a longitudinal study around concussion and TBI. So we'll put that link also on the platform in terms of being able to enter data in if you've got access to concussion patients. That's really important research. If you're thinking about research priorities, literally 2 weeks ago in the UK, the Research Forum produced this document, which is the Concussion and Sport Priorities for Research from the UK Research Institute. There's lots of stuff in there to unpack. It's not too much of a long read, but long-term neurodegenerative disease burden is one thing. Biomechanics and how that relates to etiology and physiology is important. Understanding on children and adolescents is important, and how it affects their developmental trajectories. Interesting research in Australia came out of Melbourne around the effects of concussion on academia, which is quite alarming if you want to read about that. Pitch of side diagnostics. Obviously, we've got Abbott Pharmaceuticals as a sponsor of this conference, and so there's new blood biomarkers for concussion and brain injury, which is really probably going to change the landscape of how we diagnose these things, particularly in ED. It's going to have lots of implications for that. Development, also looking at the psychological and psychiatric outcomes, treatments and novel technologies, which you've seen a few of them today, which are up and running and using in clinical practice. We'll continue to use this tech. We need to know where it fits and where does it go and when is it vital, when can we hold back on it. But technology is certainly changing things for the better. Assessment, the impact of guidelines and protocols. We want to know if we do have guidelines or we do an education program, are we actually changing practice? And so at Your Brain Health, we're particularly interested in tracking that to see whether 6 months, if we do a GP course, in 6 to 12 months' time, do people actually change their practice in any way? And if they did, what was it that they changed? And that will help us improve our education. And then there's strategies for prevention and all these kinds of things, which becomes particularly important as well. So there's a lot going on. I can tell you from where my headspace is at the moment is developing some software. So we're developing a software called Screen It, which will be out in 2025. We're pleased to say it will have all your usual tests that you know and love. It will have the scats and the scopes that John talked about this morning, and then they'll be free to be used. You'll also be able to track people's outcomes, which is a lot of feedback people will be wanting to do. So each domains will be tracked, whether it's symptom domains, whether it's the VOMS domain, whether it's the mental health domain. We can track those sorts of things. We're interested in not just concussion, but also the fact that we've got software and outcome measures that are recommended for healthy ageing and brain health. Also, neurological conditions for my MS patients, tracking their brain health report, my stroke patients, for my ageing patients in terms of reducing their risk factors for Alzheimer's. we need to be able to add in a few of these things to track them, not just do MRIs. We do a lot of clinical measures in allied health, which can help track disease progression, so that's important. And of course, I get to talk to very interesting people in relation to sporting performance, everything from Formula One to Premier League soccer to all these things. And I'm a sports nut, so I'm quite happy about this. But the stuff that we're talking about today is not just about concussion, it's actually about rehabilitation, it's actually about performance. And so that's been really interesting. Our software will be about multimodal report generation. We want you to be able to collect your data, it spits out a report, takes your Neuroflex stuff, takes your SCAT stuff, your VOMs, puts into a report, and then you can send that to the GP. And then it's much more digestible. We want to be able to track people long term. We're now 3 or 4 years down the track of now having baseline screen people repeated. That means we're actually saying it's very easy, within 15 minutes once a year, keep a track of your brain health, which is really important. We include technology like Neuroflex to plug into it, and then the online community platform, which I hope you guys will jump on and have a look at, means we're very keen on having accessible, free, informative information out there for clinicians all around the world. We've got people from the UK, South Africa, from Japan, from the US, from Canada, coming on board, sharing ideas, so that we get out of this silos, we get out of this, how do you do things in South Australia? Well, I'm actually quite interested in how people are doing it in other places in the world as well. So the technology will have, mobile phone concussion recognition tool, but most of the data collection will be with either iPads or with your laptop. And you can see that we'll have not just stuff around concussion, but everything from sarcopenia to grip strength to timed up and go to the HUDAS for disability to short physical performance battery for your oldies. So brain health is big. We've been talking about concussion today, but it quickly turns into discussion about other important aspects as well. It's all about efficiency. We're building this for clinicians, okay? But I do have a research part of my brain as well, but we're also aware that researchers will be interested in the fact that we're collecting data, and that data will help them, as in researchers, answer certain questions. So if you are interested in research, please talk to me, because as we're building the software, we want to make it very research friendly. And then a lot of work being done to make sure that the data is safe, that it's ethical. You can't just screen people and expect that solves problems. I can't go into a school and screen mental health if we don't have a school nurse or a psychologist to be able to follow up. So in some situations, we won't be testing mental health, but in other situations we will, and we have to look at the ethical responsibility of screening to make sure that we minimise harm and maximise benefits, and also make sure we use fair data principles, so that if a big company comes along and wants to look at our data, it will be ready for them to utilise. So that just gives you some idea of where we're going as Your Brain Health. We want to be facilitators of a lot of education and support. So please watch this space. The big aim of today was to make you guys network with each other. So that will be the first aim. So when you go onto the platform to see what people will be talking about, besides having the references and the slides from all the talks, we want some interaction. You can do it at your own pace, but knowing that it's a space where we can get some good global opinions. If any of you know me, I'm a big sharer. I mean, I really want to make sure that information is accessible. We're not competing with anybody. We just really, it's an exciting field. And we're at a stage now where we think the next 5 or 10 years is really exciting. And finally, lots of thank yous. Lots of thank yous to all our speakers today for giving us really good clinical pearls. I don't know what else to say, but thank you. Log on to the network. Please, if you've got any questions you want to follow up that you just got home or you're in the middle of the conference during the week, you think, I forgot, please put them on the network. We'll make sure that we're on there, we're answering, we're putting things on there. Hopefully you guys can interact and you can find your people. So thank you very much, and I'll let you go and have a beer.